Okay, well, once again, welcome everyone to the PRAPARE Tiger Team. We'll go ahead and get started. Yuriko, can you confirm that you can see my screen?
Yes, I can.
Okay, thank you. So welcome to session 11, where we are going to be talking about PRAPARE workflow models. As a reminder, we do encourage participant engagement throughout our session. So we will be using Zoom. So if you have any questions or comments throughout the session, you can raise your hand, add it to the chat, or also use the reaction emojis as well. These are the Tiger Team facilitators. My name is Nalini Tarrant. I am the Director of Social Drivers of Health, and I will be co-presenting today with Yuriko Dela Cruz, who is the Deputy Director of Social Drivers of Health. And then we also have Chloe Destinoble, who is the Project Manager, Equitable Health and Wellbeing, and she will be helping to monitor the chat throughout today's session. And while this presentation is being led by NACHC, I'd like to point out that PRAPARE has been a collaboration process with APSHO and OPCA. Okay, so I think we're going to try and launch a Zoom poll just to get a better sense of who we have in our virtual room this afternoon. So I believe Yuriko might be able to start it.
So this isn't actually the poll, it's just the chat. The poll is in the next slide or so. So I think folks have already started to drop their name, their organization, and their state in the chat. So thank you all for joining us. And we'll be sure to launch the poll very shortly. I think it's the next slide. So,
well, the next slide says the learning objectives. So this is beyond my tech skills today.
Starting at noon, 11 Central on
I think, and it's okay if we can't get the poll. If folks just want to go ahead and introduce yourself in the chat, name, title, and organization, that would be great. Yuriko, does that work instead?
the poll that we have is on slide 9. My apologies. I should have updated the slides to reflect that. So folks are dropping in the chat where they're from. So thank you everyone for dropping where you're joining in from, your health center, your title, and your state. So then we go ahead and go on to learning objectives. Slide 9 will have the poll there. Sorry about that.
Okay. Fun stuff. Okay, so for today's session, here are our learning objectives. We're going to spend time exploring the 5 rights framework as a guide to determine potential workflows for PRAPARE. We're also going to look to understanding various workflows and related staff models that can be implemented with PRAPARE. And lastly, we're going to spend time digesting considerations and lessons learned related to the workflows that we will be reviewing this afternoon. So we're just going to dive right on into the 5 rights framework. So collecting data on social drivers of health using PRAPARE can be accomplished in a variety of ways. And while there may not be an absolute one right way to implement PRAPARE, the 5 rights framework, which looks at the what, how, who, where, and when, can provide a fundamental guide for achieving effective implementation of PRAPARE. So in adopting PRAPARE, you really want to spend some time considering what information you are collecting on a routine basis. This includes any existing data or assessments related to SDOH. You want to make sure that you're not duplicating efforts while also ensuring that PRAPARE complements any existing data collection. Then you want to look at how to collect the data by reviewing your current data collection methods. With this understanding, you can work to devise a clear plan for administering PRAPARE to ensure that it accurately and respectfully captures individuals' SDOH needs. The third pillar in this framework is who. Who will collect this data? Here you want to identify individuals or roles responsible for collecting the PRAPARE data, in addition to who will address any identified SDOH needs. It's important to clearly outline responsibilities and to also ensure the assigned individuals have the necessary training to collect sensitive information. From there, we can then begin to consider where to collect this information by exploring and identifying suitable data collection settings that prioritize individuals' privacy and comfort, Remember, we're collecting SDOH data, which is lived experiences. So we want to make sure that individuals have that sense of privacy. And we also want to be respectful, and that will help to have an open communication channel between the staff members and the individual that is being screened. And lastly, you want to consider when to collect the data. Establish the right timing for administering PRAPARE by considering the most appropriate moments during healthcare encounters to gather this information. And so today we're going to be going over several workflows, 8 in particular, to as examples of ways where you can implement PRAPARE. So I believe this is a poll that is up. So the polling question that we would love to capture today is, which of the following workflows does your organization use? And you can check all that apply. Are you using non-clinical staff, maybe before, after the clinical visit? Maybe it's the clinical staff that are conducting the PRAPARE assessments during the visit. Are you tapping into the expertise of care coordinators or chronic disease management team? Maybe using interpreters as well for folks who English is not their first language. Maybe you're using the no wrong door approach or self-assessments as well.
Thank you, everyone. So far, we have about 30% of participants responding. If you're at an HCCN, no, don't worry about that. You can definitely close out of the poll. That's fine. Thank you for asking that, Colin. So I think we're about 45% now. So we're almost at 50% of attendees. And so we'll give you all about a couple more seconds, maybe 20 more seconds to complete the poll. And no worries if this isn't relevant to your work. We know we've got some folks from PCAs, HCCNs, that's totally fine. We just want to get an idea of where folks are at. And we'll be sure to keep this in mind in the future. So thank you.
I'm not seeing where the poll is. Can you drop the link in the chat?
It's within Zoom. So you might have to go to the actual window. I'm not sure why it's not showing up on your screen. And if you don't have it, just let us know which workflows you use in the chat. That's totally fine as well.
Okay, I found it. Thanks.
Okay, great. Cool. Glad to hear that. All right, great. Thank you. Yes, Latanya, it should be a pop-up. All right. So we'll give you all about, so we're at 60% of folks completing it. So we'll give you about 10 more seconds to complete it, and then we'll close it out and see what the results are. Certainly fascinating on my end, so I'll be excited to share the results shortly. Okay. And go ahead and close the poll at this point. We're at 60% that have participated, so thank you. And so these are the results. Can you all see the results of the poll? You should be able to see the results. Are you able to see the results?
Yes.
Okay, great. Yeah, so about 56% of you use clinical staff during the clinical visit, so that's great to hear. And then we've got about 48% using non-clinical staff before the visit, and then care coordinators during the medical visit. So that's really great to hear. And then we've got other folks using other approaches. So it's really great to see the variety in different workflows that are out there. So thank you for completing that. And then I'll hand things back over to Nalani.
Thanks. Well, actually, I think Eureka, you're up. So I will go ahead and advance your slides. So we'll move on to the next slide.
Awesome. Thank you. So thank you, everyone, again, for taking a moment to complete the poll. And really, before we go into each of the workflows, we wanted to take a moment just to remind ourselves of the different patients that we see. And so we wanted to present this patient story. It's a mock patient story. This is not their actual picture. But we have Malik here. He's a new patient at the health center. He's a 38-year-old African-American male. He's a husband and a father of 2 kids, and he works a full-time job at a factory, but then he also does rideshare driving 3 times a week. He is on medication for high blood pressure, and luckily it's within normal range. So that's where he's at right now in his care. So on the next workflow, on the next slide, we'll see the first workflow. Here on this particular workflow, we're seeing that what we have is this first clinical workflow is using non-clinical staff, my apologies, after the clinical visit. So with the first workflow, we're considering doing prepare screening with Malik after his medical appointment with non-clinical staff person. And when we talk about non-clinical staff, we mean patient navigators, patient advocates, community health workers, eligibility assistance workers, outreach and enrollment workers, amongst others, right? So we wanted to acknowledge those are the non-clinical staff members that we've identified, but again, we know that there's other titles that are out there. And so when we think about why we would want to use this particular workflow, there are several reasons to consider this workflow. First is that, non-clinical staff are typically employed from the community. And so they have an easier way or they're more easily, it's easier for them to relate to patients, and they also understand some of their needs, and they're able to build trusting relationships. And many times non-clinical staff are really aware of the available community resources for patients, but then just everyone in general. And then it also ensures that the staff person administering prepare also addresses the needs. So this is something that this workflow is really helpful with, in terms of the person who's asking the questions can also follow up on the needs. Some advantages with this is that it doesn't delay the visit with the provider, and that automatically provides a warm handoff between, for once the needs are identified, then the person that's identified those needs can then connect the patient with different services and resources. So in this particular case, Malik is already able to share kind of what his preferences are in terms of different resources that are available to him. Now, there are some trade-offs with this particular workflow, being that it's after the visit. Malik's provider does not have this information before the visit. So the provider is not able to use that information during the clinic visit to inform care. So that's one of the trade-offs. The other one is that it could lengthen the overall visit time, and I've seen it many times in some health centers or healthcare settings, is that after the medical visit, maybe the patient really has to get going. So in this case, knowing that Malik has to go back to work, or maybe he's got to pick up his sons, that's a trade-off that might be that we'll have to consider for this particular workflow. So then in the next slide on that workflow, all right, what we've got here is using non-clinical staff, but in this particular workflow is before the clinic visit. So Malik has already checked in to his visit. As he's waiting to get seen by his provider, someone from that's non-clinical will then do the prepare screening with him, right? So this is during the patient waiting time, if you will. And so at this point, again, non-clinical staff, as we defined earlier, could be patient navigators, CHWs, patient advocates, et cetera. And so the reasons to use this model is, again, to make sure that the staff that would be administering the prepare could also address any needs that come up during the screening. And then we're not using billable time from providers, right? We're not using the time of billable providers. We're making sure that we're leveraging the time most appropriately. Some advantages to using this before the patient visit, or the clinical visit, if you will, is that the prepared data then is readily available, right? So Malik has shared all his needs with the non-clinical staff person, and then the provider can then have that information during the visit, and then they're able to really work with Malik to find the best treatment plan to keeping his high blood pressure controlled, right? We want to make sure that we have that. We're also able to then really leverage that value added time when, the patient would just be waiting around to see the provider. So that's the other advantage for using this workflow. Now, some trade-offs to consider is that, and this has happened, is where your non-clinical staff person, your CHW, is likely doing the prepare screening before the patient visit, and then, here we go, the provider's ready and they want to see the patient right away. So then, that CHW and Malik, they're working together to complete the prepare screening, but then now the provider is like, well, now I'm able to see Malik at this point. So then that screening does get interrupted. And so that's something to keep in the back pocket in terms of this could happen. And then possibly this could delay the visit as well. So, want to keep that in mind in terms of being able to see if this is a good workflow for your team at the health center. Okay, so on the next slide, with that one, the third clinical workflow is actually, this one is using clinical staff during the clinical visit. So again, in this particular case, Malik has Malik is checked in, and now he's in the exam room, right? And so during the time that clinical staff would be doing the vitals, that would be the time that the clinical staff, let's say the medical assistant, will go ahead and also ask Malik the prepare questions after the vitals are taken, right? You want to make sure that, you know, you do some of the exam visits, some of the vitals during that appointment, but then once those vitals are done, then you can ask the prepare questions. At this point, then, you know, the provider will have all that information that they need. And then the patient, in this case, Malik, would then be referred to someone non-clinical to address the needs after the visit. But at this point, at least the needs are identified before the provider gets into the room, and then they're able to then use that information during the clinical visit. And so what's great, some of the reasons to use this model is that many of our clinical staff are already trained and have experience in collecting sensitive information. So this is part of their repertoire already in terms of being able to ask these sensitive questions. The other advantages, or some of the advantages with using this workflow, is that by waiting to do prepare in the exam room, it ensures privacy. It ensures that, you know, we have this one-on-one conversation with Malik, and that it's in a private setting, so he's able to share as honestly as possible. And then that prepared data will then be used during the clinical visit with the provider. And let's say the MA is the one that's rooming for that provider. They can give their provider a heads up. Hey, just identified these two needs that Malik has. Just wanted to let you know. And then at this point, then the clinician, she'll have the information that she needs to provide care for Malik. And then some of the trade-offs that will have to be considered for this particular workflow is that we're using billable staff to conduct assessments, right? We know that, you know, within the clinical visit, there's time is precious. And so there's that acknowledgement that we'll have to use billable staff to do this assessment. Again, the same trade-off that has been mentioned before is that the prepare screening could be interrupted if the patient is if the provider is already ready to see the patient. So that's something to keep in the back pocket. The third one is probably the most important one, is that we already know the rooming process is filled to the brim with a lot of different items and tasks that the MAs have to do while they're rooming the patient, right? And that's something that would have to be considered in terms of determining if this is the most appropriate workflow for Malik. And then finally, the clinical staff may not be as knowledgeable about community resources to respond to needs. So in the other examples that we had seen with non-clinical staff, being that they were able to do the screening, they already have a good awareness or knowledge on resources. So in this case, by using clinical staff during the clinical visit, we may have clinical staff that don't know, and they're not able to provide the resources or respond to the needs that Malik has identified during that rooming process. So those are just some considerations for this particular workflow. And then in the next workflow, for the fourth one, we have here is, you know, with this particular workflow, Malik will have the prepare screening completed by a care coordinator during the clinical visit. So in this particular scenario, the patient, Malik has already seen his provider. He and his doctor, they've already spoken, and his provider, she has already referred to him to see a care coordinator because in her time with Malik, she's determined, you know what, he could benefit from care coordination, right? She's uncovered some things in her discussion with him, and she feels that he would be most beneficial to have a care coordination appointment. So then at this point, Malik is then seeing a care coordinator who will then administer prepare. And what's nice about this particular assessment or this workflow is that care coordinators, oftentimes they administer multiple types of assessments that collect similar or complementary information. And some of these assessments could be mental health screenings, depression screenings, domestic violence screenings. We know they look different in every health center or every setting. So they're already collecting this information. So adding prepare to the assessments could really add value to their work already, given the role and given their goal in working with patients within this particular domain. And so then from doing the assessment, then the care coordinators can provide intensive or interim care coordination for the patient. So with this particular scenario, Malik, you know, you know, something has been identified from his provider, he's connected with his care coordinator, and now they're working out a plan that includes his medical self-management plans, but also what sort of social needs need to be considered with that. And so he's able to do this together with his care coordinator, and there has to be some level of agreement there. And so some of the reasons to use this, as I said already, similar information is already being collected, and there's that coordination piece that could be really figured out with Malik and the care coordinator. And then having this done at the same time with the care coordinator can really just allow Malik to have his needs addressed at the same time. And then the trade-off really with this particular workflow is that care coordinators also have other care coordination responsibilities. We know they have a panel, so to speak, of other patients that they're managing in terms of their care coordination responsibilities. And so they may be limited in terms of time for doing prepare, but at least at this point, we can think about, does this make sense for Malik in this particular scenario? So then I think at this point, I'll hand things back to Nalani.
Great, thanks, Yuriko. Okay, so before we go on, I just want to see if there's any questions on the 4 models that Yuriko went through. I'm not sure if Chloe has any questions so we can address. If not, we'll continue on.
Anu did have a question, excuse me. Anu in the chat said, even if the prepare screening tool is available for the provider, how much time are they spending with patients to discuss the impact of prepare scoring results?
Yeah, I think that's you know, I think that's always really tricky. And I think with many times what I've heard in terms of the clinical setting is that it depends on, you know, the need and also kind of where Malik would be at, right? So if this particular case, if there's a lot of needs that that Malik has, then they're going to have to talk to their provider. So I think really it's more than likely there's still going to need to be a team approach. So at least the provider's aware, they're not going to address it. They're at least aware, okay, if Malik is having all these different jobs that he has to do, and he's managing his hypertension, at least the provider has that in her mind in terms of how to best support Malik with his care planning, right? Providers almost 10 times out of 10 will not be the ones that will provide housing or transportation. But again, this at least allows them to be informed with that. But that is a great question. And I think we can certainly keep that in the back of our pockets. And I'm going to be in the chat looking at the questions as well. So, and slides will be provided afterwards. Yeah. I know that was one question that came up.
Yeah. So moving on to workflow number 5 is having the chronic disease management team implement prepare during the clinical visit. So let's say Malik has an appointment. As Malik enters the exam room, he is greeted by dedicated staff. Right at the start, the chronic disease management team member takes a moment to explain the purpose behind prepare and how it's going to play a pivotal role in shaping Malik's care plan. So remember at the beginning when we introduced Malik, he is a new patient to the health center. So this would be his first time encountering prepare. And it's all about really making sure that Malik understands that the chronic disease management team is there to provide the best care possible, and that prepare is a vital tool in that process. So together, Malik and the team members sit down and embark on a conversation. They navigate through prepare, discussing each question, concern, and consideration. It's more than just answering questions. We really want this to be a genuine dialogue between the two. The staff member is not only a listener, but is also recording Malik's responses. And together at the end of the conversation, they review the prepare responses and determine if Malik needs or is interested in being connected to any available resources, which could be in-house or in the community. If no needs are identified at that time, the staff member may want to flag that in the EHR or maybe make a note that during the next annual appointment to rescreen Malik again with the prepare assessment. So reasons to use this model is that it allows you to prioritize high-risk patients, ensuring targeted care where it's needed most. An advantage of this model also is that it can foster a collaborative atmosphere between clinical and non-clinical staff, creating an environment conducive to prepare data collection and team discussions to inform care. Also, many times, the chronic disease management team may already be equipped with techniques such as motivational interviewing skills. However, the trade-off with this model is that it could potentially extend the visit duration So you may want to factor in more time for each patient encounter. As we move on to workflow number 6, using interpreters before the clinical visit. So in the diverse and dynamic world, we recognize that community health centers are serving patients speaking a variety of languages and that they also come from different cultural backgrounds. So this is where workflow 6 comes into play, a model that ensures a language is not a barrier to quality care. So imagine Malik when he checks into the front desk, the staff member inquires about his preferred language. This small but vital detail sets the stage for a seamless experience. At this point, we identified that Malik does require language assistance, so an interpreter is made available to administer PRAPARE. Together with the interpreter, Malik navigates PRAPARE, discussing each question and concern. The translated version of PRAPARE, also printed on paper, is provided to ensure that Malik can comfortably follow along through the conversation. I will note that PRAPARE is available in over 20 languages and it can be downloaded on our website. If there is a language that we have not yet translated PRAPARE into, please let us know and we can begin that process. So once the screening is completed, the information is shared with the provider in English or in the EHR chart so that it can be used to inform Malik's care plan. The provider, interpreter, and Malik come together to have a conversation to review the PRAPARE responses and also maybe part of that clinical visit as well. They explore whether Malik requires and desires connections to available resources and whether they can be found within the facility or the community health center or out in the community. And just as in any model, there are both advantages and trade-offs for this model. Interpreters do more than just translate. They can actually provide a valuable explanations and cultural context to prepare questions in the preferred language, which can ensure that patients fully understand the context of the questions and can provide a more accurate response. Also, if we are hiring interpreters from or recruiting interpreters from the community, this can play a critical role in building trust and meaningful relationships with patients, which helps to foster an environment of comfort and understanding. However, some of the challenges that we can face with this model is that interpreters may not always be readily available. Administering PRAPARE with translation will take more time. And while this model aims to administer PRAPARE before the provider visit, there is a possibility that the assessment could be interrupted if the provider is ready to see the patient. Okay, so now we're on to workflow model number 7, which is the no wrong door approach. This is designed to be flexible, allowing various staff members to seamlessly integrate PRAPARE into the existing clinic workflow. This approach divides responsibilities across staff, ensuring that every patient's unique needs are considered throughout the visit. Oh, did I just move that slide? Yeah. So let's walk through Malik's experience as he arrives at the health center. At check-in, the front desk staff engaged Malik in a brief conversation about his demographic information related to registration. So this can include details such as his address, race, ethnicity, preferred language, insurance, veteran status, and maybe even family size and income. As Malik moves on to the exam room, the clinical staff may begin to administer the other PRAPARE questions in addition to taking vital signs. This early integration of PRAPARE data collection allows the care team to understand the broader context of Malik's health from the very beginning of his visit. The provider enters the room to conduct the clinical visit while also utilizing the insights gathered through PRAPARE. At the end of the clinical visit, the provider hands off Malik to a non-clinical staff to obtain any additional resources and to continue with the checkout process. At this stage, the non-clinical staff carefully review Malik's PRAPARE responses and have a conversation with Malik to make sure that the information has been collected correctly. If needs are identified, they may connect Malik with available resources and continue to with the checkout process. If no needs are identified, Malik is checked out as usual, and the staff may make a note of this in his chart. So this model comes with its own set of advantages and trade-offs. On the positive side, it lessens the burden of any one staff member by distributing responsibilities across multiple staff. This approach ensures that everyone has an opportunity to help paint that fuller picture of their patients, leading to a sense of shared responsibility and staff buy-in. Yet, it's essential to consider the trade-off. This model requires coordination to ensure that staff are aware of who is collecting which data points. So therefore, we're preventing duplication of the questions asked to the patient. Also, not all staff may have access to the EHR for inputting of data. So we would want to make sure that the folks who are working on the PRAPARE assessments does have that access to the EHR. So that way it doesn't complicate the data management process. And also additionally, another trade-off is that dividing responsibilities across staff, it can make it challenging to pinpoint a single point of accountability. So you're going to want to take those trade-offs into consideration if you are trying to move forward with this work model. And our last workflow model is number 8, the self-assessment approach, which offers an innovative way to collect PRAPARE data, particularly in cases where there's a large patient population or a limited number of staff available for in-person screening. This model is also an opportunity to align PRAPARE data collection with other patient communication and engagement methods. So to make this model work, the PRAPARE form is transformed into an online platform, often within the patient portal. The first step is to ensure that there's clear messaging about the purpose of PRAPARE and how it can positively impact a patient's care plan. Before the official launch, rigorous testing should be conducted with both staff and a small cohort of patients to ensure user-friendliness and comprehension. Only once all the kinks are worked out should the PRAPARE notification be sent out to all of the patients or members of the health center. And so let's consider Malik's experience in this scenario. He receives a notification. This could be by email or maybe by text, prompting him to complete the PRAPARE form before his upcoming visit. So Malik fills out the form to the best of his ability. And when he arrives for his appointment, the staff are already equipped with the PRAPARE results and ready to discuss the next steps with him or have that conversation with the data, that information that Malik has provided through the patient portal. The self-assessment approach has a range of advantages, including rapid and efficient data collection that can cover a broad section of the population, all while imposing minimal demands on staff resources. This swift data acquisition can also be a valuable asset for shaping care improvements and strategic population health planning. However, it's essential to consider the trade-offs as well. This approach may not directly facilitate patient and care team relationship building, which is a vital component of comprehensive care. And this method primarily reaches patients who are email literate and can access the platform, potentially excluding those with limited digital literacy or access. And furthermore, if you're trying to capture that real-time feedback of patients' experiences completing PRAPARE, that this model doesn't necessarily capture that at that point in time. Okay. And so I believe that was a very high level of 8 workflows that can also be found in the PRAPARE toolkit. Eureka, I'm going to look at you to tell me what chapter again that's in.
Chapter 5, that is the chapter of interest on the PRAPARE toolkit. And we actually have some questions in the chat, so I wanted to see if we can answer them.
Sure, we can definitely answer.
Okay, cool. So with one of the questions, or actually there's one comment from Wanda about having social workers or behavioral health complete the screening. You know, it's something that she shared in the chat, and really just wanted to acknowledge their workflow in doing that, because then they're able to, you know, have the resource connections that they need to follow up on any referrals or what have you. There's a question from Judy of if we have medical assistants serving as care coordinators who are doing the PRAPARE and assisting the patients to access resources, coordinating care outside of the clinical visit, can this be counted as enabling services? And I would say yes. I mean, the fact that you have someone that is, you know, they're, first of all, they're medical assistant, they're able to not just only gauge the social needs of their patients, but then follow up on any sort of care coordination, that could be counting as enabling services. The next question that we have is from Sandra Knight, and she asked, who is part of the chronic disease management team? And this is part of what Nalani was referring to earlier in one of the workflows with chronic disease management. I know one of the health centers that I worked at, they had a team that was specific working with individuals that had uncontrolled diabetes, right? So this is someone that, you know, their blood sugar is uncontrolled. They need more intensive services, right? And so that would be the care management team. It's more than care coordination, is really a very specific, dedicated, It's typically a nurse. I would say it's typically a nurse that does that. It could be also a myriad of different chronic diseases. Could be hypertension as well. Because Malik's hypertension is controlled, don't think he would be, you know, going to like a chronic disease management team at the health center that maybe works with patients that have hypertension. But because the provider, she saw that he had some needs that could use some care coordination, that's kind of like that step down approach, or that right before he gets to uncontrolled hypertension. So hopefully that answers your question, Sandra, in terms of, you know, just an example of a chronic disease management team. But I know there's other examples out there. So if folks have examples from the field, please drop those in the chat. And then let's see here. I'm still in the chat here. We had Anu who talked about how they have PRAPARE questionnaire automated in their platform. And that was actually before Nalani started reviewing that workflow. So they were able to share that gem. And so with this particular one, if you can share the EMR platform that you use, that'd be great. We know that there are some that have active license agreements with NAC on using PRAPARE, and they do have it automated, right? And so it does take some refinement, like Nalani said. You do have to do some fine tuning, but it is there and it is possible. But yeah, definitely have to take a look at that. And that someone had mentioned in the chat, aside from just doing the screening, you still have to have a process for who's reviewing the results and who's going to actually address it. So I think that's the other consideration, is that, you know, we've got the information. What are we doing then to address these needs? And then we have some comments here. Let's see here. Renee said the workflow that has the least burden on the clinical staff is the one best received. Yep, the clinical staff are burned out. That they are, right? And it makes a lot of sense. We're seeing more and more that there's more health centers and PRAPARE users that are shifting the PRAPARE screening away from clinical staff. We know a lot of providers don't do it, but, you know, just shifting that away from clinical staff has been very helpful. We have a question here from Lorna. Are the translated PRAPARE forms on your website the final draft, or are you still working on them? What's on the website is the final version. And I see Nalani shaking her head, yes. So if there's a need to update them or fine tune them, I believe you can contact us.
Yeah, I would say, yeah, Eureka, you're right. The prepared translated forms on our website are the final versions. However, if you feel that we are not capturing it correctly, you can email us and we can work with you to better rephrase or retune the way that the question is worded. All the ones that have been translated, they did go through a process where we use a translation service. And then we worked with community health centers to make sure that they were culturally appropriate and linguistically appropriate. But we also understand that maybe there might be some edits or insights that we could rephrase those ones. And if there is a language that we have not yet translated into, but you need it, please email us and we can put that on the docket as the next one.
Thanks, Nalani. So I already see some folks have dropped in some thoughts in the chat in terms of what are some of the lessons that they've learned with finding the workflow that best fits their staffing models and the needs of their patients. We have some folks that have said that they're using more CHWs in terms of piloting the integration of PRAPARE. So that's a really great lesson learned. Thank you for sharing that, Renee. And then Colin has shared, as a patient myself, I tend to disregard pre-appointment screening requests in the portal because almost every time I get grilled face-to-face during the visit anyway, even after putting in the effort to fill out the form in advance. So it's easy to run into duplication of patient effort, not just duplication of clinic effort. Yeah. So I know sometimes there's a delay in that. I remember when I worked at a previous previous job, a lot of times what was completed in, let's say, MyChart and Epic, it took some time for that to actually filter over into the EHR. So it was really difficult there. So thank you for sharing that, Colin. That is a reality. So that's, again, where that fine tuning has to happen. And then Angela has shared in the chat, we have some that are using kiosks and have added PRAPARE to the preventative screenings completed by the patient. Yeah, so I think I've been seeing that more and more, as well as many others have seen that there's actually like a tablet or a kiosk where folks register and they're able to complete that. So Thank you for sharing that. If folks would want to share, if you want to come off mute or just drop it in the chat, we'd love to hear any of the lessons that you've learned in implementing Prepare, in finding the workflow. That'd be great to hear. So Latanya has dropped in the chat. I have experienced a few of our health centers asking if there has been any thought or discussion around changing the order of the questions. Okay, I was talking, then I got muted. So I think with changing the order of the questions, I think that's fine. I think it's whatever makes the most sense for your patients. I know sometimes in the EMR that might be tricky to actually do that. But if you're able to make those changes, I would definitely recommend that. And Latanya shared they're interested in having more serious questions like domestic violence before asking about migrant workers. Yes, that makes sense to change the order, right? If you're limited on time and maybe that'll be interrupted, you want to front load some of those questions. That's a really good, would love to see that. And then any other lessons learned? Okay, Cindy adds, she changed the order of the questions to match the order in our EHR and not duplicated demographics. That's brilliant. That's perfect. That's exactly how it should be done, Cindy. So thank you for that. And then Laura has shared, we have actually incorporated some of our questions in the new patient paperwork and in front desk check-in, and the rest are administered by a patient advocate or CHW in the office. Yeah, that's really a great way to kind of level load or just kind of add the questions where it makes sense for that patient visit. So that's really a great example there, Laura. Let's see. And I know Angela dropped in the chat, ECW has developed a good workflow for using the kiosk mechanism. That's great to hear that. Yeah. Many times if you partner with your EMRs, they will give you some sort of solutions that they have. Do we have EHR templates for Prepare administration? Those are actually with the EHR companies. I think there used to be some templates, but you know, we wanted to respect their request that that they're only available to their customers, which makes sense because they're making changes all the time and they have the best resources for that. Nalani, if there's anything else.
Yeah, that's exactly right. So we provide, once an EHR has an active license agreement to build out Prepare on their platform, we provide them the PDF version of Prepare, which can be downloaded off our website, and they are the ones who then build it out into their platform. So we don't have access to how it's built out. We don't like do any of that with them. We give them those just the PDF for them to build out and then to work with their clients on how they want to, I guess, rephrase or recapture those questions. So I know some EMRs are more lenient on modifying where the questions are, and others may require more conversations on why you are requesting to move those questions around.
Great.
Yeah, I just had a question. So I've been sharing and doing I've been following your toolkit, NACHC, great, I love it. Some of the links are dead, and so I don't know if I just don't have the most current updated version, but you had a lot of support materials that now are dead links, and so you know,
I've noticed that
one dead
too.
link, just like, no, this document is old, it doesn't work, and they just ignore me.
Thanks for that insight. If you know which links those are, you can email us and we can give you those proper documentation. We are in the process of updating our full toolkit to being responsive to Prepare 2.0, which we plan to do a soft launch at the end of the first quarter in 2024.
So Renee, when you said that the links don't work, is it the links from the prepare.org website?
It is.
Links from in the toolkit to a resource page on NACHC.
Okay.
The page on NACHC has disappeared.
Okay. All right. Thank you.
Yeah, Eureka. I've noticed that too. Some of them that don't work from our exact website. Now, if it goes to a different website or an external party, maybe they have discontinued, which is something that we'll have to go through with a fine-tooth comb and update.
So thanks, Renee. Let's see here. So we'll address that in terms of some of the links not working. Hannah has dropped in the chat, IU Health texts patients 7 days before their primary care appointments and learned that there are better response rates in the late afternoon, evening hours. That makes a lot of sense. So that's just one tactic for folks. Cindy said that they use the paper form answered by patients and then enter it into the ECW smart form. And then Emily said that that is also their workflow. So that kind of, that's a workaround for like the restrictions within the EMR. Like if you can't make the changes you want to make, at least on the paper form, you have the order of the questions and the way that you want it. And then you just have to make sure that those get entered back into the EMR. So that makes a lot of sense. Someone did private chat me and said that some EHR vendors have said NAC won't allow them to modify. So Nalani, I know that's not true.
That's inaccurate. So I would say whoever, I know your private message to you, if you could let me know who your EHR is, we can definitely recircle back with them to make sure that they are allowed to modify the placement of the questions. What we do ask is that if you are modifying the responses to the questions, as in you're adding additional responses, we'd like to know what those responses are, so that way we make sure that it's still in essence with the validation of the tool.
And Renee, I still see you have your hand up. I'm not sure if you still have a question. Okay, I just wanted to make sure. And then we've got from Sandra that she worries about using kiosks and she doesn't like doing prepare on paper when she can avoid it. Has been experienced that when patients do these screenings on paper, some patients do not always understand the questions. And I also worry about people with low reading abilities. So when asking prepare face-to-face with patients, it is much easier to ask clarifying questions and improve the comprehension of the questions. Absolutely. I think there's always, we're always going to have different patients and different understanding levels, reading levels, all sorts of things. So I think what we hope is that you have different options for different scenarios, right? Many times we want to select one workflow for everybody, but that's not usually the case. So hopefully these are just some examples of what can be possible in your health center. All right, and then we have something from Hannah. Has the NAC team worked with ECW to learn more about why the prepare is inaccessible? We'll flag that and follow up with them. I'm surprised to hear that. Okay, yeah, they're great partners. I'm not sure what happened there. So I'll go ahead and keep us moving along. Thank you for sharing your lessons learned and even some of your challenges and how some of this has kind of looked like in real life. On the next slide, just wanted to provide just some very high level overview in terms of, some promising practices when it comes to workflows and to lessons learned. And honestly, a lot of you have already shared a lot of what I'm already going to talk about. So these are just the three big items, if you will, or the three big promising practices that we hope that you've all can think about. And the first one is fitting prepare into the clinic workflow. And, we know that this is something that when it comes to introducing prepare, or when it comes to doing this, there's a lot of angst, right? Many staff feel reluctant to collect more data simply because they feel that it will be hard to fit it in their busy workflows or work days already, and then it could possibly lengthen or disrupt the clinical visit. And so for all of us, it's really for us, it's really important that we identify value at a time when patients could be waiting, and see what are some ways that we can automate this or really help our staff really understand when to complete this. So we've heard from some users that they've created prompts or pop-up questions or even a flag in the EHR to say, hey, this needs to be collected or the prepare needs to be done. And as we heard from some of you already, you've already crosswalked and integrated prepare with other screenings, with other efforts. And so you've been able to really find the right pieces that work together when it comes to prepare screening. You've also had thought about how to respond to identified needs and knowing that this will require more time or other staff. So it's also really important to take a moment to discuss this really important phase, because it's one thing to screen and to assess, but then what do we do with responding to those needs? And that's going to take some fine tuning as well to find out what works best for you all. And then we want to make sure that all staff that works with patients has access to prepare data to reduce the same questions being asked several times. I know in several states, sometimes there's some restrictions in terms of what like CHWs or patient navigators, what they could access in the EMR. So that's something to consider in terms of trying to find the right workflow and the right staffing model for that. The second promising practice or lesson learned is being aware of the emotional toll on staff. And this is really something that, you know, is important to keep in mind. You know, we know that staff may experience an emotional toll when collecting data on the social drivers of health. And this could be even more magnified, and they don't feel like they can address the needs that have been identified, right? We can't unhear that, we can't unsee those needs. So we want to be mindful to that, to the emotional toll on staff. We also want to keep in mind that for staff that are directly employed from the community, they may also experience an additional emotional toll if they've also experienced similar socioeconomic challenges. And that could be, these challenges could be current or something in the past. So we want to ensure that, you know, as we work with using Prepare at our health centers, we want to ensure that staff, that the organization, we want to ensure them that you know, the messaging is really for our staff is that we as an organization need to start somewhere, and that the data that we collect will allow us to inform programs and referrals to meet the needs of patients. And really this messaging is for maybe programs you don't have in-house, or resources that you don't have. So this is really tough, right? When we're asking them to collect data and to identify a need that we can't respond to, we have to message that for our staff members. We also want to make sure that we provide and create some sort of emotional wellness support to staff, especially those that are in distress, right? We want to make sure that we're able to decompress, we're able to maybe even process some of the challenges that we've heard and share those within a team setting or within a one-on-one setting with our supervisors, and being able to have those check-in on how things are going. And then really when we're thinking about how to best support our staff, this is a great opportunity to see what our organization's community resource guides look like and see if there's anything that's lacking, seeing if the, you know, if there's a way to track the information so that staff are able to identify any sort of additional partners or resources or services. So again, that helps with our emotional toll, managing that for our staff. And then finally, you know, making sure that patients and that staff understand that understanding and knowing a patient's socioeconomic situation helps to inform care and treatment plans so that we're able to really use a whole person approach. And so with Malik in mind, knowing that he is working, he's working 2 jobs, he's got a family, he does have hypertension, he does have high blood pressure, he is taking his medication, so far it's controlled. Knowing all these things about them is really important, and so really allows us to help us understand how to keep him as a whole person in mind as we develop his care plan. And then finally, really when it comes to promising practices with workflows, is really making sure that we take the time to educate and train our staff. So we want to make sure that that staff at all level have some level of understanding as to what Prepare is, the importance of it, and why the organization is collecting this information, and how it adds values to our work. And then we also want to ensure that all of our staff understand how this information will be used to care for all of our patients. So folks that are front desk, billing, it's important that they understand why we collect this information. And then we also want to make sure that any staff that's collecting this information is trained in empathic inquiry, talk story approaches, anything that helps them with collecting the sensitive data so that they're able to really build relationship with patients. And then finally, I know we're running down on time. We've had such a good discussion so far. Wanted to just, this slide may look familiar for some of you if you've attended previous sessions. We've used this slide in the past, and we just want to acknowledge the fact that from the patient perspective, SDOH screening is a good use of time. It's a good use of conversation, right? And so we want to acknowledge the fact that it does take a lot of time and effort to find the right workflows, you know, depending on the staffing models that you have, the resources within and external to the health center. But it's all a worthwhile investment, right? So if we're able to make this investment, if we're able to really take the time to think about which workflows might work best for different scenarios, and it's okay to take the time to really walk through that and outline that for staff and team members so that they're aware of what's happening. But again, just wanted to emphasize this particular slide in terms of patients like this. And even if you can't address every need, this is important for them to help share their lived experience, their circumstance with you all as their care team, as they're coming to you all for their care. So at this point, I think we'll go ahead, and the next slide is we have our Prepare user survey. We just launched this, and so we're going to be doing this annually. We have been doing this, and we're going to do it again. So here's the link to the Prepare user survey. We did cut down on some of the questions, and we're really hoping that you all take the time to complete it so that it could help us understand, you know, how you're currently using Prepare, how to best support you all and your teams in using Prepare. And then the next slide.
And hopefully maybe Chloe can put the link in the chat, because I can't seem to grab it. And then our last slide here.
Okay, and then last but not least, on a separate but very important related note, our team is hosting a post-conference workshop at the 2023 PCA and HCCN conference. You know, this post-conference workshop is, you don't have to go to the PCA conference, but if you're close by and this is something that you and your team wanted to join, well, definitely join us for this. This is really around exploring health center pathways to health equity. And so really with this, it's not SDOH data collection, it's not Prepare specific, there's some interrelatedness, but really what we're looking to do with this post-conference workshop is to really understand what are the long-term impacts of structural racism, oppression, and bias in healthcare in the communities that are being served. And so I see Chloe has dropped the link for the survey. So thank you for dropping in the survey. And this slide deck will also have a link to the post-conference workshop. So just wanted to share that opportunity with all of you. We do talk about some SDOH data collection, but it won't be the nuts and bolts, if you will, of workflows and that sort of stuff when it comes to data collection. So just wanted to share that. I think that is it.
Yeah, so that wraps up our session this afternoon. We will be sending out the slide deck as well as a link to the recording as well from the YouTube channel that we have. And I believe there are other previous Tiger Team sessions on there if you're interested in reviewing those. And just as a reminder, we do want to get feedback on Prepare. So that annual survey is really, really important for us to get your feedback or insights. You can fill it out, your colleagues can fill it out. That's really going to help us determine how we can address barriers and gaps in Prepare and in our programming in the coming year. And I think with that, everyone have a great week. Thanks for joining.
Thank you. Have a great rest of your day.
Bye, everyone.
Bye.